A patient presents with a bone protruding through the skin, a traumatic open fracture. Yet the compliant billing code for this encounter is often closed treatment. This creates a trap for coders who try to map an ICD-10 diagnosis directly to a CPT treatment code. ICD-10 is the system used to classify the injury itself, while CPT identifies the specific service the doctor provided. You must separate the injury from the treatment. In orthopedic coding, the two do not have a direct correlation. Code selection depends on the provider's physical intervention. The classification of the injury exists independently of what the surgeon actually does. We will examine the three primary treatment categories, define the mechanical terms used in operative reports, and walk through the bundling rules that govern these claims. Success in orthopedic coding requires a shift in logic. Focusing on the procedure rather than the diagnosis prevents claim denials and audit failures. Every fracture intervention falls into one of three distinct mechanical categories within the CPT system. Regardless of the method used, the goal is always the same: to stabilize the bone and return it to its correct anatomical alignment. The distinction between these three categories depends on how the surgeon accesses and secures the bone. These methods are closed treatment, open surgical treatment, and percutaneous skeletal fixation. Identifying which of these entry methods appears in the operative report is the first step in the coding process. Closed treatment describes any intervention where the surgeon does not make a surgical opening at the fracture site. Though the site remains closed, it does not mean the provider is passive. Many closed treatments involve significant physical force. The most frequent active technique in this category is manipulation. Manipulation is the manual reduction of a fracture. Reduction is the process of realigning bone fragments using only the provider's hands or external force. Traction is the second technique used in closed scenarios. This involves applying a continuous pulling force to align the bone without exposing the fracture site through an incision. These active interventions are different from simple fracture care, where the bone is already in a position that will heal without manual adjustment. These actions correspond to specific code ranges, such as 25600 to 25609 for the wrist, or 26700 to 26705 for the hand. The same logic applies to larger structures. For the tibia or fibula, closed treatment codes range from 27750 to 27758. If there is no surgical incision, the coder must select from the closed treatment bracket, regardless of the severity of the injury. Open treatment is defined by the surgical exposure of the bone. Unlike the external force used in closed treatment, this method requires a literal opening of the tissue to reach the fracture. Once the site is open, surgeons typically perform internal fixation. Internal fixation is the placement of hardware, like plates, screws, or pins, directly onto or into the bone to hold it in place. This direct anatomical access increases the complexity of the procedure, which is reflected in the higher values assigned to open CPT codes. For major long bones, coders look to brackets like 27500 to 27516 for the femur, or 27800 to 27802 for the tibia. When reviewing an operative report, you must look closely for specific mentions of an incision or exposure of the bone. It is important to distinguish between a wound caused by trauma and a wound created by a surgeon. If a fracture is visible through a traumatic wound, but the surgeon does not surgically extend that opening to treat the bone, it does not count as open treatment. In CPT, open refers to the surgeon's act of opening the site, not the patient's condition upon arrival. The third category is percutaneous skeletal fixation. This is a hybrid method. It is not fully open, but it is more invasive than a standard closed treatment. Here, the surgeon stabilizes the bone by driving pins or wires through the skin and into the bone fragments. Because the surgeon cannot see the bone directly, they use imaging guidance, like fluoroscopy, to visualize the placement of the hardware on a screen in real time. Beyond these three categories, every fracture claim is governed by universal bundling rules. These are part of the Global Fracture Package, a set of services that are included in the primary procedure code. One of the absolute most common compliance errors in coding involves the initial application of a cast or splint. The first cast applied during fracture treatment is bundled into the surgical code. It cannot be built separately. The subsequent removal of that initial cast is also part of this bundled package and is not a separately billable event. Claiming these services individually during initial care is a compliance error. To handle exceptions to these bundling rules, coders use modifiers. Modifiers provide the specific context necessary to explain why a service should be paid despite the standard bundling rules. Use modifier 54 when the surgeon performs the initial repair, but another provider takes over the subsequent care. This ensures the payment is split correctly between the person performing the surgery and the person handling the follow-up visits and cast removal. Modifier 76 is used for repeat procedures. This applies if a fracture slips out of place and requires a re-reduction, a second manual alignment, during the healing period. Note that modifier 56 has a specific restriction. In fracture treatment coding, modifier 56 for preoperative care is never used. When reviewing an operative report, the final workflow comes down to 3 questions. Did the surgeon open the site? How was the bone stabilized? And which services are already covered by the global bundle? Effective coding requires looking past the injury and focusing on the incision and the method of fixation. Compliance is found in the procedure, not the